This is the patient who's neutropenic on chemo for leukemia. It's a really great example of this process.
I'm thinking typhlitis. So neutropenic
Yeah.
colitis.
Here's a venous.
Typhlitis with intussusception. And wait, the mucosa is like breaking down. The wall is breaking down.
Yeah, right. See if I can give you the windows. Oh, long windows. There's no free air, but you have one with the TI, the right colon, cecum, mucosa is falling apart. There's areas here, for example, that are non-enhancing, air bubbles kind of extending to the, actually through the mucosa, yeah?
Yeah.
Probably pneumatosis. Yeah, so this was necrotizing enterocolitis in an adult patient. Excuse me. This is just a really great example of some of the radiographic findings that we can see. And I mean, we see this more in children, but I mean, I didn't realize there was a staging, but there's a staging for necrotizing enterocolitis. Like I said, this is typically for infants, but I think it's just as the severity gets worse, like in this case, probably close to stage 3 here. That patient, often requires surgery, and this patient did undergo surgical resection, and it was necrotic intraop.
Okay, I have a question for you. When you're saying the patient was neutropenic, so is this typhlitis too? Isn't that the same thing as
Yeah,
like?
I think so. I think it's just another name for it, no?
Okay, got it. Okay. Well, it's interesting that you showed that because I have a similar or companion-ish case. Hold on. Oh my God, wait, did I not record this?
I wasn't paying attention.
Okay, I think I didn't. Okay, I think I didn't record. Okay. Okay, so here is an interesting companion-ish case where we see this intussusception of the ascending colon here. And anytime in an adult, when you see an intussusception, you have to go look for a lead point. We can see that there's like fat and mesentery being pulled in, very edematous colon, but not like with the mucosal breakdown that Nelly had. And no lead point. We don't see it like a lipoma. We don't see a cancer. So, and then the question was whether or not this filling defect in the SMV was real. You can see it here. But on the coronal, you can see that it's kind of where these two sets of vessels are flowing in together. And there's this sort of like laminar flow appearance. So we thought this was maybe just, it was raised that this could be a thrombus and, leading to ischemia. But in the end, this patient ended up going to the OR. This was actually all ischemic terminal ileum and colon. And then we got a follow-up MR, and the SMV was completely open. So there wasn't actually a thrombus. It was just a mixing artifact in the SMV. But for some unknown reason, there was ischemia of the terminal ileum and colon that ended up leading to an intussusception. They underwent a right hemicolectomy, so now the rest of the colon is normal here. So, okay.
This is an older study, and they're looking for median arcuate ligament syndrome.
I was going to say, it looks like a hooked
Yes,
celiac plexus.
that's right. That's right. So there's a protocol, CD protocol to look for this, and the protocol requires an inspiration. So this is the inspiration view, and then an expiration. So this is the expiration view here. And as Aarti already shared, this is a celiac artery here, and there's a hook appearance. So where it gets pinched is right here. That's the median arcuate ligament. And this is inspiration, and then on expiration, it gets worse. It exacerbates that condition. And here is a radiographics paper that explains the anatomy of why we see that. So so the median arcuate ligament is supposed to be above the celiac artery, but sometimes it can congenitally be located at the level of the celiac artery and can cause problems. So it pinches it off, and then you get this severe, or the severity varies, but you get stenosis and then poststenotic dilatation. So the inspiration expiration protocol. So inspiration is this one, and then expiration is this one. So when you expire, it makes it worse. So in this case, we see it on both, and it gets worse on expiration, but we see it pretty prominently on the inspiration view as well. So if you're not sure, then you can get this protocol to kind of induce it. Uh, and here, a really nice example. So this is a normal celiac axis, and there is no kink. But then when you do have median artery ligament syndrome, then you get this pinch, just like this here. There.
Wait, and stay on that image right there, right there.
Yeah.
There's two ancillary things you're supposed to see. Like one is this, dilated pancreaticoduodenal arcade, where it is like, so because your celiac axis is pinched off, your SMA is going to retrograde feed your hepatic artery by going up that pancreaticoduodenal arcade. So you're supposed to see like dilated vessels of the pancreaticoduodenal arcade. That's supposed to like say that it's actually clinically significant that your celiac axis is being pinched off.
Oh yeah, and that's a good point. Here in figure B, there's collateral kind of supply from the SMA retrograde, and then here the paper is pointing at this GDA that's kind of chunky to compensate for this stenosis of the celiac.
And I think that's supposedly why it leads to abdominal pain, maybe because it's like pulling blood away from the SMA that would normally be feeding the bowel.
That makes sense.
And then the other thing, well, so it's like a diagnosis of exclusion. So like if you just see kinking, a lot of people, you can incidentally just see kinking on CT, but if you don't see these collateral vessels, they don't have abdominal pain, then like it probably is just incidental. The other thing you can do is an ultrasound to look like to see if there's accelerated velocities in the celiac axis.
Yes.
So for your patient, what are they planning to do?
Oh, this was like
You don't know.
a study from
Because
10 years
sometimes
ago.
they'll like do a little release maneuver.
Oh, got it. Yeah, no, sorry. This one, I just wanted to show an example from one of our old cases.
Cool. Okay. This is a young female who presented with abdominal pain and bloody diarrhea. Focus on the colon.
That's helpful. The left colon, it's thickened.
Yeah. So
And there's
I
not a
thought
lot of stranding. It's a pretty long segment.
yeah, let me show you.
Probably involving the splenic flexure too, like kind of like the watershed zones.
Okay, so here is the thickened colon you were talking about, which I thought
Yeah.
was a really good call because you could just say like maybe it's just decompressed. But there's a little stranding and it definitely looks thickened and long segments extending from
Yeah.
watershed splenic flexure down the left colon.
Yeah.
So what would you call this?
The
The vessels
vessels
look
look pretty
good.
good. It's open. I would include C. diff. Probably, it's your infection, inflammation, ischemia, DDX.
Mhm. So excellent. So and a lot of times we think young person, like vessels are fine, they were an outpatient, whatever. This is probably not going to be ischemic, right? So we were like, okay, this is maybe an infectious colitis. We didn't see any other findings of inflammatory bowel disease, no small bowel involvement. And the person who read this just happened to specifically say no evidence of ischemia, no pneumatosis, no evidence of it, like no abnormal enhancement of the wall. And my gastroenterologist said to me, like, why did you guys say no evidence of ischemia? I think this could be ischemic colitis. And we're like, well, the vessels are all open. We don't see any additional findings. But anyway, they went to colonoscopy and they did biopsies, and this was actually severe ischemic colitis in a young
Ooh,
female. And so
from
it was a good teaching lesson for us, which is that basically, it's not just we think about ischemic colitis as like a disease of older patients, and you're going to see more severe findings. But you can actually get them in young patients. So I looked up a few things about it. So, and when you have ischemic colitis in younger patients, it's very much female predominant. Many of the patients are on oral contraceptives, so they might have like a thromboembolic kind of like phenomenon, or like microangiopathic kind of occlusion. It can also be seen in the hypovolemia. So it can be seen in patients who have like just been like, like hanging out at the beach and dehydrated, and then they actually get ischemic colitis, or even if they're like running a marathon and then, just like not hydrated enough. So yeah, that was, and how they treat it is they basically do IV fluids, antibiotics, and then usually colonoscopy to sort of diagnose it.
Lactate, right? Isn't that kind of diagnostic or no?
Yeah, and actually, that's a good point. I didn't look up the lactate on this patient, but she ended up going to colonoscopy pretty quickly, and the biopsy came. They said visually it looked like ischemic colitis, and then the path came back ischemic colitis. So yeah, but yes, probably follow serial lactates too. But so don't forget about it in young patients. And then we talk about watershed area, which is splenic flexure and rectosigmoid area. But actually, this paper I looked up about ischemic colitis in young patients, they said the vast majority are in the left colon. So, just because it's a longer segment involving the entire left colon, don't exclude ischemia.
This patient was a horse handler and came in with like signs of infection. And the patient like had pain in the back and stuff like that. And I got a lumbar MR, which showed like edema in the left iliopsoas muscle. Let me give you the fat set right there. No evidence of osteomyelitis discitis, but lots of inflammation there and stranding, and presumably presumed to be infected. Um,
I feel like is
Posterior
a horse
elements.
handler some kind of clue, but I don't know any
Yes. Yeah,
equine
I didn't know this
diseases.
either. So the patient had persistent pain, and the infection that this patient had was actually with this bacteria, Strep equi bacteremia. And what I learned from the providers was that that is extremely rare in humans. It's a infection common to horses, extremely rare. But this patient had it and had bacteremia from it. And in humans, they can cause vascular complications, vasculitis, things like that. And we knew that this was happening in the spine, kind of paraspinous muscles. In addition, they were also looking for vascular complications that is commonly attributed to this organism in human infections. So they got a CTA to look for vasculopathy. On the CTA, we see all that stranding, lots of stranding, along where what we saw on MR. Right there, a lot of stranding, and it kind of progressed. And we just got an angiogram because they were looking for specifically for vascular, like arterial complications. I guess this is more of a companion case to the earlier study that you showed with your case of ischemic colitis.
Oh, so am
But
I
there's
supposed to be looking at the colon? No.
no, the veins.
Oh, okay. Yeah, I was gonna say the IVC looks really distended more than like I don't see an arterial abnormality, but yeah, the IVC maybe even has a thrombus in it.
Yeah, exactly. It's kind of an arterial phase now, but I think I think maybe on the sagittal, that's where I picked it up on the sagittal.
Yeah, that
Was
definitely is concerning, and and it also looks kind of expanded. And so is it like sort of a septic thrombophlebitis? Because like,
Yes, that's the what's being thought, or that's the kind of the working diagnosis. And the patient subsequently got a venogram to confirm that new clot in the IVC. I don't know if it's
mm,
like septic or just like post-inflammatory clotting from all the stuff that's happening in the posterior, like prevertebral space. Um, but
Wow.
you can
Do you know
see.
how they got it from the horse? Just by handling?
Oh, I probably. I don't know how the patient was handling the horse, but
Okay. And then I guess they must have some antibiotics or something for it.
yeah, yeah.
Okay. Very cool. Never heard of it. And you've only affirmed my decision not to be able to handle horses. Okay, hold on one sec. Okay. So this
Ooh,
is a
where is
lesion.
that
Okay,
coming
so
from?
this is the uterus here. And
Yeah,
then you
it's
can
getting
see that there's actually like
displaced.
a stalk coming from the uterus onto this exophytic heterogeneous lesion. And there's there's a fibroid there. There's a fibroid down here.
Sarcoma of
So
some
yeah,
sort.
this is kind of like our like fibroid versus leiomyosarcoma, right? And it does look very heterogeneous, but it's well encapsulated. It doesn't have infiltrative margins. It doesn't have definite intratumoral hemorrhage. And I don't have an ADC value for you because we didn't do an MRI. But I'll just say that this was watched for years and it
But there's
was,
lots of stranding. There's not. It doesn't. I don't know. There's something going on. There's. Go ahead. Yeah.
so there's some fluid. Anyway, it was pretty stable for a while. And then they were lost to follow-up and they came back and
Ugh.
it looked like this.
Ugh.
So the exophytic lesion has grown. There's still like a separate uterus over here, but it's kind of like blending in with this huge exophytic lesion. So we were
Yeah.
like, okay, this was a leiomyosarcoma, but weirdly, this had been going on for like 10 years, where it's slowly growing over time. And also there was no Mets. There's no, pulmonary Mets, nothing like that. So anyway, it was resected and this turned out to be a uterine stump tumor. So we've
Wow.
talked about stump tumors of like the prostate and other places, but so it's basically a stromal tumor of unknown malignant potential. It was not neither benign nor definitely malignant. It just has some cytologic atypia. These patients have to be followed up for a long time because they can present with metastatic disease many years later. So that's the main takeaway, which is like, this is great for this patient. This wasn't actually a leiomyosarcoma, but they still need to be followed for a very long time. And I don't think it's a retrospective diagnosis. I don't think you could ever prospectively call this. You basically go in thinking either it's a fibroid or it's a leiomyosarcoma and it comes back stump.
Wow.
So
Renal mass, MR for characterization. And
this will be
so
a
we
good
have,
one for CCLS.
yes, yes. So this is a good one for CCL. And I'll tell you what I CC
I
it.
can
I
actually
left it
probably
as,
do it while
but
you're
you
showing
tell
it.
me. Yes, let's do it. So here's your pre, and then your arterial. Okay.
Yeah.
And this is your 5 minute. Is this, yeah, here's the subtraction, 5 minutes right there. All right, a little bit of misrestoration, a little bit of motion too. T2 is right here.
Wait. If
Yes.
you kept up that arterial and the delayed side by side,
Yes,
are we seeing
arterial is
like
here and delayed is here. Okay, side by side. Uh-huh.
are we seeing segmental enhancement inversion where like
I don't think so, but you tell me. So
the
here is
segmental
arterial.
enhancement inversion is like the part that's dark. So for example, anteriorly, oh no, wait, it's getting a little brighter. And then the
Okay, this is
posterior part that's
arterial.
bright is getting darker. I would call that segmental enhancement inversion.
Oh, I didn't catch that when I was reading it, but I think you're right. Right? Because the posterior part, it's enhancing and then washes out, and then the
And then,
anterior part is not enhancing, but then there's a delayed
yeah,
wash in.
yes. Okay,
Oh,
keep
good
going.
catch up. Okay, all right. That's a great pickup. Okay, sorry, what else did you want?
I want the
I,
T2. I'm
T2.
going
Okay,
down
here's
the
your T2.
outline. The
Here's your T2.
T2, you have to say, is it like the dominant enhancing part, although the whole thing is enhancing, is it hyper ISO or hypo intense to the,
Hyper. Well, I said it was hyper, but what do you think?
I would say hyper, but this is a really tricky one because like parts
Yeah.
of it hypo, but yeah, I would say hyper. And then you
Okay.
say, is there moderate intense or mild enhancement?
Let me give you the pre then. Here's a pre. I put intense, but
I think it's
here.
intense. So
Yeah.
intense is greater than 70% to the renal cortex. But you know what?
What?
You're actually looking at the part that's T2 hypo. So if we're gonna be looking at that enhancement,
Yeah.
well, anyway,
I
the
just look at the
signal
most
is supposed to
enhancing
be
area, but maybe I'm
mature.
doing it wrong.
It's just that it has two different parts. But anyway, okay, so let's just say intensely enhancing.
Okay.
Your
And
microscopic
then,
fat.
oh, fat. So here's the in and a pose. Here's your pose. And here's your end face. Okay. So here. And this is where I had a question about.
I think there's microscopic fat.
I thought so too.
So
Good. I'm glad we agree.
definitely.
Right?
Yep.
And it's not a fake out.
Nope.
Okay, great. So I got this to be CCLS 5.
Yes, that's what I got too.
Okay, great. So this was biopsied, and there was not features of clear cell per biopsy, and the differential diagnosis per our pathologist was an oncocytoma, which makes sense with this segmental inversion,
Yep.
a chromophobe RCC, among others. Features of clear cell RCC are not present.
Mm.
So I didn't see this initially when I looked at this, but I guess that makes sense now with the path results from the biopsy. Um, and I didn't know that oncocytomas can have fat, interlesional fat.
Yeah.
But this is biopsy, so not surgical path. So I don't know.
Which actually is very like it can be very inaccurate. By like just not completely reflective of the whole tumor. Like a lot of
Yes,
diagnoses get changed on final path. But
that
I
makes
will
sense.
say, like, just based on that segmental enhancement inversion,
Yeah.
I um I could see how. Oh, wait.
Oh,
I gotta show you something. Okay, not this. This. Okay, look. So this is the CCLS algorithm, right?
yeah.
And you know how you just said you didn't know chromophobe or oh wait, no, actually the microscopic fat only shows clear cell. And if it's no, it goes to oncocytoma. So yeah, I think it must be really rare. But that was definite microscopic fat.
Good.
And it was
All
pretty
right.
convincing segmental enhancement inversion. And I will say, like, when I've talked to Yvonne about these cases or shown him some, like he
Yeah.
will say, like, oh yeah, rarely you can get that. You could rarely like an oncocytoma can have fat, or rarely,
Yeah.
XYZ, so
Well, here's a case of onco with fat, presumably.
cool. Okay, Nelly, what do you think about this prostate?
There's UroLift clips in there.
Yay! So this is just a shout out for UroLift. So in we often when we see metallic things in the prostate, we think about brachytherapy seeds. But if you see that there's only like two sets of them, two sets on the inside and two sets on the outside, that is a UroLift procedure, which is like for BPH, where they kind of try to pull apart the prostatic urethra by using this UroLift device. And I'll just show you a picture of it. Oops. Okay, here it is. So they put their device in and then they deploy these metallic things. And so on imaging, we're going to see the two internal metallic parts and then the two outer ones. And then, hopefully it'll pull apart this prostatic urethra. Is this effective or as effective as TERP? Apparently that this has a lower long-term efficacy than TERP. However, shorter hospital stays, less complications, and much lower rate of urosepsis. So it's getting more popular these days. So that's it.
Thanks so much.
Yeah, thank you. Bye.
Okay, bye.